Okay, so now let's talk a little bit about saccular and aneurysm, which is another name for aneurysm, cerebral saccular aneurysm, which are true aneurysms, meaning they involve the three layers of the blood vessel. Now, as you can see, we are talking about cerebral aneurysms. So it's in the brain, and it's aneurysm, it's pouching of the blood vessel, and it's aneurysm, which is a saccular aneurysm, which again is a pouching of the blood vessels, and again it's a true aneurysms. Mainly they involve the three layers of the blood vessels. They are important to identify because if they are large, we will see higher likelihood to rupture and cause subarachnoid hemorrhage, the complication. If they are very small, we will see, and in the arterial circulation, they have reduce risk for rupturing, and if they are bigger, especially in the posterior circulation, they have higher likelihood of rupturing. So we will talk about those aneurysms in the brain, those aneurysms. There are some associations to diseases. We will see it. So let's start. Here is an aneurysm. It is taken this image from radiopedia. You see here in the tip of the basilar artery, you can see in the circle of Willis, we have this tip of basilar artery. There is here a pouching, which is usually hyperdense. In a CT, we usually take CTA, CT angiography, to make the blood vessels more pronounced. So you can see this pouching in the basilar part, in the tip of the basilar artery and part of the circle of Willis. So this is a posterior circulation aneurysm. You can measure it and see what is the size, which will help you in stratification. What is the risk for rupture of this aneurysm? This aneurysm may be asymptomatic until there is a rupture. Here is a drawing of the circle of Willis with a aneurysms. You can see basilar tip aneurysm is 8%. Most commonly placed for aneurysms, it's in the arterial circulation, those are 90%, and in posterior circulation, those are the 10% left. In the cerebral aneurysms, now in the arterial circulation, the most common part is in the anterior communicating artery or anterior cerebral artery. In this place, especially in the bifurcations, the aneurysms develop. As you can see here, the percentage. MCA, which is bifurcation at the bifurcations, like in M1 right over here, is another common area. Internal carotid artery bifurcation is another common area, and anterior bifurcation in the posterior communicating artery. So those are the common places for aneurysms in the arterial circulation. In the posterior circulation, you can see here the basilar artery, sometimes in the superior cerebellar artery. But again, posterior circulation is much less common than aneurysms in the anterior circulation. 90% are in the anterior circulation and 10% are in the posterior circulation. But remember that posterior circulation aneurysms are more likely to rupture if we are talking about a certain size. So they may be less common, the posterior aneurysms, posterior circulation of the circle of Willis aneurysms, but they may be more prone to rupture and cause a hemorrhage and causing usually subarachnoid hemorrhage with all its manifestation, usually headache, thunderclamp headache, the worst headache in their life. It can be with reduce of uh, mental status. So aneurysm again, the intracranial aneurysm usually, and the saccular aneurysm as a part of them, usually is composed of the three layers of the blood vessels, tunica intima, media, and adventitia. This is the externa. So the three layers are part of the pouching that is caused in the aneurysms, the saccular, the aneurysms, and it is called true aneurysm, when it involves all the three layers. Usually the intracranial aneurysms are true aneurysms, like the saccular aneurysm, like the aneurysm. Okay, now there are predispositions and risk factors. Some of them are related, for example, for hypertension. Some of them are related to other diseases like connective tissue disease, like Marfan, like Ehlers-Danlos type 4, like antitrypsin deficiency, and we will see it. And what you can see here is hyperdense material in the subarachnoid space. This is subarachnoid hemorrhage, and the most common cause of subarachnoid hemorrhage in the non-traumatic presentation is a saccular aneurysm. It's a Berry aneurysm. So look for it, do a CTA, and look for the aneurysms in patients with non-traumatic subarachnoid hemorrhage. Now, we will see the sizes, but this is an example of a very big aneurysm. When the aneurysm is more than 25 millimeters, it is called a giant cerebral aneurysms. Those aneurysms more likely to rupture, but may also cause symptoms prior to the rupture. Even sometimes just before the rupture, they can do symptoms. Of course, as you can see, this can cause a pressure on the brain parenchyma, and especially on the chambers, on the ventricles, and may even cause, I don't know, hydrocephalus if it didn't cause it yet, and things like this. As it can be seen here, it can compress the brain parenchyma. Now, Charcot-Bouchard aneurysms are aneurysms in the perforating artery in the, for example, basilar part. As you can see here, you can see the basal ganglia. So the perforating arteries, when there is a hypertension, may dilate, because of the hypertension, for example, may dilate focally and create those aneurysms. So this is another place for Berry aneurysms to develop in patients with chronic hypertension. It can be in the basal ganglia, in the thalamus, in the pons, in the cerebellum, and it is coming from the small perforating vessels, as you can see right over here, as those perforate the basal ganglia in this picture that is not mine. I think it's for, I don't know. This is the MCA. You can see here the lenticulostrial arteries right over here that are small penetrating arteries that develop because, for example, hypertension, those pouching of aneurysms. Now, this is not so common but not so rare, about some 0.2 to 9.8, usually asymptomatic patients. And you need to remember that if you see one aneurysm in a patient, look for another one, because 15 to 30% of those aneurysms that are in asymptomatic patients are multiple, and the patient has more than one. Family tendency is a risk factor, because if you have more than one relative, first degree relative with aneurysms, with Berry aneurysms in the brain, you have around 30% to have also an aneurysm. So family history is important. Now you can see here part of the associations. I didn't give all of them, I didn't write it down, but you can see collagen diseases like Marfan, maybe Ehlers-Danlos type 4. You can see polycystic kidney disease, which is related to Berry aneurysms, neurofibromatosis type 1, coarctation of the aorta, and you can see the other things, the aneurysms in the abdominal aorta, I think I meant to say. Now, what are the clinical manifestations? I talked about it. It can be asymptomatic until there is a hemorrhage, subarachnoid, usually, sometimes intracerebral or subdural, and subarachnoid hemorrhage presents usually with thunderclap headache, the worst headache they had in their life, with reduced consciousness, maybe after some times meningeal sign, I think, that can also present with, but those are the most common ones. Now, as I said, giant aneurysm may even cause symptoms before the rupture, maybe prior the rupture. So if they're developing symptoms, it may hint that there is a rupture that is going to happen. Now, pathologies, usually the bifurcation, outpouching, usually true aneurysms, namely from the three layers of the blood vessel, the intima, media, and adventitia. It may have more thrombus and it can change the imaging findings, how it looks on imaging, and it can develop irregular outline. And where it ruptures from the dawn of the aneurysm. Now, this is the location, as I said, and the prevalence for each one. You can see that most of the aneurysms are from the anterior circulation of the circular fluid, and just 10% are from the posterior circulation, basilar, SCA, and PICA. So from here, this is 10%, and anterior circulation much more common, where the most common area is the anterior communicating and anterior cerebral artery, but also in the bifurcations of the middle cerebral artery, the MCA. Remember the word bifurcations. It is a very important area for developing aneurysms. Also ECA, PCOA, so posterior communicating artery with the internal carotid in here, as we saw, can develop also aneurysms. Now, there are terminologies for the size. Under 5 mm is considered small, more than 25 mm is considered giant. And imaging technique, especially for blood vessels, so CT angiography, MR angiography, and the gold standard that is less used because it's invasive, is the DSA. Now, what we expect to see in CTA, as you can see here with CTA, you can see here the aneurysms, and may have calcifications and upon contrast. It depends. It can be in uniform enhancement, like over here. When the aneurysm is patent, when it is thrombused, you may see rim enhancement with filling defect because of the thrombus. Now, MRA, okay, usually the contrast is in T1. In T2, you will see here hypointense, and in thrombus, you may have a lesion with a rim hyperintense. In T1, usually with contrast. If it's the aneurysm patent, you will see flow void. If there is thrombus, it depends on the thrombus age. This image is not very good. It looks like a rim enhancement with the thrombus aneurysm. Except for this, I don't have much to say. Okay, here you can see the difference between the risk to rupture between the rupture from the anterior circulation, which is much less than the risk of rupture from the posterior circulation. Luckily, more commonly aneurysms develop in the anterior circulation, where the rupture is much less common compared to the more rare occurrence of aneurysms in the posterior circulation, where rupture is more commonly occur. You can see here that under 7 mm of aneurysm, the risk in the arterial circulation for rupturing is 0, so it's very unlikely to rupture. But giant aneurysms are very likely to rupture, especially if they are from the posterior circulation. Again, posterior circulation under 7 mm, there is more risk for rupture compared in the anterior circulation. Those are the treatment options if you want to treat, for example, if it's a giant aneurysm, but if you want to observe, if you want under 7 mm. Anyway, those are the options for management. You can do coils, endovascular coils, and surgical clipping, and etc. I won't get into it. Now this is a DSA. You can see here an aneurysm, and okay, this is it. This is all I wanted to say about berry aneurysm and cerebral saccular aneurysm. You saw how it looks. You saw the etiologies, the pathologies with the true aneurysm. You can see the locations, anterior circulation, posterior circulation, bifurcations. You saw how important it is in the risk of rupture, giant aneurysm, compared to small aneurysms, and the imaging findings. Thank you very much. If there are any mistakes or corrections about a saccular cerebral aneurysm or berry aneurysm, please write in the comment below. All the images and sources are not from me. It's from Radiopedia. It's from other images from the internet. So there is no. I tried to wrote it down from where I took some of them. Some of them I forgot. Anyway, thanks for all who gave the images. And this is it about saccular cerebral aneurysm and berry aneurysms. There is not all that can be said. Also, sometimes you can measure the neck of the aneurysm and the ratios of the aneurysm, and it can help you get to decisions. I didn't talk about it, but there is in Radiopedia, for example, they talk about it, and I want even maybe to show you this. You can see here that they're talking about the aspect ratio and the size ratio and the area ratio, where I didn't even talk about. But thanks for Radiopedia very much, and thank you all very much, and this is it.